Good morning, friends. Today I am going to discuss with you the anatomy of pterygomaxillary fossa and the pterygoid implant. So, why it is important to know the anatomy of pterygomaxillary fossa or pterygoid region? Because we all know nowadays most of the implants, in full mouth cases also, we are doing tilted concept and we are placing pterygoid implants, and pterygoid implant is a proven now that it helps to have a better anchoring, better stability, and in full mouth cases most of the time with minimal invasive way, sinus lifting, grafting, augmentation is avoided. So that's why it is more important to know the anatomy of pterygoid region. And believe me, if you consider the pterygoid implant as the blind implant, then every implant you do is a blind implant, because we all know we are practicing in small clinics, so managing the complication in clinics is a bit difficult if we violate the anatomy. So why it is important to know the pterygomaxillary fossa? Because it is far away from what we are doing in our clinics. So basically we will discuss pterygomaxillary fossa and little bit about the pterygoid anatomy also. So let's start. So this is a printed model actually I am going to show you. So here it is a pre-maxilla, zygomatic arch, nasal aperture. Now when it is maxilla, it is also a maxilla, and these are palatine bones. This is maxilla, these are palatine bones. So now what is this? Pterygoid region. So it is basically a part of sphenoid bone and it has two wings, two plates, medial pterygoid plate and lateral pterygoid plate. So pterygoid implant is basically a junction of three bones. One is a maxillary bone, maxillary tuberosity. Another second is a palatine bone, pyramidal process of palatine bone, and this is the sphenoid bone. So these are the plates, lateral pterygoid plate and medial pterygoid plate. These two plates are the parts of sphenoid bone. So clinically, medial pterygoid plate, there is a one extension. It is called as hamulus. Whenever we make a denture, we palpate actually, and the pointed thing we palpate is a hamulus, and hamulus is a distal extension of medial pterygoid plate. So medial pterygoid plate, and this is lateral pterygoid plate. Lateral pterygoid plate has two muscle attachments. Laterally, lateral pterygoid muscle, and medially, medial pterygoid muscle. So this junction is very hard because it is made up of three bones, junction of three bones. It is a 13 mm junction from this, and pterygomaxillary fossa, what we call, it is far away from this area. So this is our target area. Whenever we do pterygoid implant, we give mesial angulation because we want to hit in between these two plates or maybe towards medial pterygoid plate and not towards the lateral pterygoid plate. Remember, lateral pterygoid plate has muscle attachment, so it might cause trismus. So that's why the angulation is a little bit mesial towards the medial pterygoid plate or in between these two plates. In between these two plates, there is a space, it is open space. It is safe if our implant protrudes in between these two plates. On maxillary artery, whatever structure, these are passing through the lateral pterygoid muscle. Lateral pterygoid plate has a lateral attachment, means laterally there is attachment. So it is far away from our angulation. So always stay away from this. So now my focus is towards the pterygomaxillary fossa, anatomy of pterygomaxillary fossa. So I am going to show you this pterygomaxillary fossa. It is also called as spinopalatine fossa. The name suggests spinopalatine, sphenoid bone, palatine bone. Pterygomaxillary means maxillary and pterygoid region, that means part of sphenoid bone. So it is a spinopalatine fossa or pterygopalatine fossa. Fissure is a different thing. Fissure comes down. This is zygomatic arch, and below this is temporal region. Below this is a infratemporal fossa or infratemporal region. So pterygomaxillary fossa is cone shape. See, on OPG we can appreciate the cone shaped radiolucent area actually. Those who are doing know there is a cone shaped radiolucency on 2D image. So on OPG also you can appreciate there is cone shape. It is like a Google logo, or I call it as Vitthalacha Tira. So it is a shape like that. So this is the cone shaped part, fossa. See, there is a difference. foramen. Foramens are basically holes. Fossa. Fossa is basically a depression. So why this depression is important? Because it is connected to different spaces like orbit, like maxilla, like pharyngeal spaces, skulls. So I am going to show you the anatomy. So what is the anatomy actually? So anteriorly it has a border, anteriorly maxilla, posteriorly this is the sphenoid bone. Medially you can see, medially this is the perpendicular plate of palatine bone. So medially it is palate, laterally it opens into the infratemporal fossa. So it is important to know this anatomy, because now I am going to show you this also. This is middle cranial fossa. So how it is connected to this fossa. So now I will show you this fossa. When you point out like this, medially it opens into the inferior orbit. This is orbit. It opens into the inferior orbital fissure. See, now I am going to show which structures or what is the content. These structures are passing through this. So to know this is the lateral pterygoid plate. This is medial pterygoid plate. This is foramen spinosum. Foramen spinosum. This is foramen ovale. And this is foramen lacerum. Foramen spinosum, foramen ovale, and foramen lacerum. This is the pharyngeal space. Stridor process, foramen magnum. First year anatomy, remember? It is like that. So, this is nasal aperture. It opens into nasal aperture. This is palatine bone. So, spinopalatine or pterygomaxillary fossa. In pterygomaxillary fossa, from the middle cranial fossa, I will show you where it goes. See, it comes here. This is basically foramen rotundum. So foramen rotundum has maxillary branch or trigeminal nerves, maxillary branch, maxillary nerve we can say. It opens from foramen rotundum into the pterygomaxillary fossa. Then on this model you cannot appreciate, but there are two another canals. One is a pterygoid canal. It also opens through this middle cranial fossa into this. So it has a Vidian nerve. We call it a Vidian nerve. And another ganglion is there. One of the four parasympathetic ganglions, pterygopalatine ganglion. As the name suggests, it opens into this fossa. That's why pterygopalatine ganglion. There are another connections also this. One goes from here and opens into the nasal aperture. This perpendicular plate of palatine bone. That is a spinopalatine. Spinopalatine. It opens here. And one from fossa into the palate. You all know the greater and lesser palatine foramen. This also opens through this pterygomaxillary and also into the inferior orbital fissure. Optic nerve, few optic nerve passes through optic canal of course, but few structures, maxillary artery and its ophthalmic division, it also ends here in the pterygomaxillary fossa region. So pterygomaxillary fossa has four structures. That is a maxillary nerve, second division or maxillary branch of trigeminal nerve, maxillary artery, pterygopalatine ganglion, Vidian nerve, pterygoid canal. So that's why this pterygomaxillary fissure is important. So whenever maxillary artery passes, it passes through the lateral pterygoid plate, through lateral pterygoid muscle and opens here. And we are putting our implants from tuberosity region towards the medial pterygoid plate, or we are hitting this junction. So this junction is 13 mm and we are placing implants here. Either it can hit the medial pterygoid plate, or it can come between these two plates, or but it will never come toward this region. It is far away from our region. But as we know, we should know the anatomy of this pterygomaxillary fossa because it has important structure. And the infratemporal fossa, we all know the pterygoid flexus comes here, posterior superior alveolar block will give, that comes over this region. So this fossa enters into the infratemporal fossa region. So remember this region, this distance between these two plates always remains constant. So what resolves? Resorption happens after extraction. So maxillary alveolar bone, it gets resorbed. So whenever in young patients or patient who has undergone extraction or just before 3-6 months, that time the ridge will be here and this plate will be medially. So your angulation should be like that. But if someone aged who has lost his teeth few years before, that time the maxillary atrophy or maxillary alveolar bone will come inside medially. So that's why it will come inside. That time this distance will remain same, but this alveolar ridge, it will come medially. That's why in those aged patients, your angulation should not be medially, but you can directly place straight because the ridge will come inside. So that's why patient's age, history of extraction, resorption, that will matter. And also on 3D image, you will appreciate on different views the anatomy of this region. So that's all about the pterygomaxillary fossa. Thank you friends.